and cons, the tips and tricks of both techniques briefly in 60 minutes. I encourage you to fit your presentation to time, please. So let us start with Ghazwan to present a case presentation in the same topic. Go ahead, Ghazwan, please share your screen. Ghazwan. Can you hear me, Ghazwan?
Hello?
Yes, Ghazwan. Please go ahead and share your screen.
Yeah. Okay, okay. I will share it. Is it okay now?
Yes.
So, okay, welcome all to our second webinar, and Ramadan Kareem to all of you. First of all, I would like to thank Muzahem and Ahmed for their great effort and welcoming Ayush from India. Welcome, Ayush. And Dr. Firas Hisban from Jordan, who is our expert today to discuss one of the debatable session, TLIF versus OLIF. So we have a speaker from, as I mentioned, Dr. Firas from Jordan, Ayush from India, and we are from Iraq, Ahmed Alqatub is the moderator. So I will start directly with my cases. She's a 60 years old female, history of diabetes, hypertension, and she had the history of lumbar spine fixation, L3 to L4, secondary to degenerative spondylolisthesis and spondylodiscitis, and spinal stenosis by L3 to L5 posterolateral fusion and instrumentation. She did well after surgery, but last 2 months she fell on the ground, presented with severe back pain, with radiculopathy to both legs, mainly to the left side. And she tried the trial of conservative treatment, failed. She had an intact urine and fecal control. This is her CT. Actually, I don't have her X-ray. I directly follow the CT. This is the level of the L3. Yeah?
Ghazwan, we cannot see the CT. We cannot see, only we can see the screen, the beautiful picture on the screen.
The slide or not?
Yeah, we cannot see the slide.
Now it's okay?
It is this whiteboard now. Did you? Okay, it's whiteboard, only whiteboard now.
It should be work because I will try again. Now it's okay?
Again, it's just whiteboard. When you go to screenshot, first, Ghazwan, did you open the presentation in your laptop? Is it up? Is it Apple?
Yes.
Okay, so go to sharing screen and choose the presentation in the sharing screen. You will have whiteboard and different options. One of the options is you'll find an icon for the presentation, which is opened and you're already open in your
system. It's only available Safari, Microsoft, PowerPoint, and desktop.
PowerPoint.
Yeah, I already optimized. Now it should work, right?
No, not yet.
Now
you are starting screenshot. Now we see only the beautiful background of your screen, but not the presentation.
Now I already choose the PowerPoint, so it should work, right?
Whiteboard again. What's Ali Sajid? Okay, no, sorry. Ghazwan, can you send it to Ahmed?
Okay, I will send.
Can you send it? I will just shift to Ayush Sharma. Tell Ahmed to prepare your presentation, and then you can show us everything after Ayush presentation. Ayush, are you with us?
Yeah, I'm there.
Sharma? Yes. Hello. Yeah. Thank you so much for being with us from India and to share your knowledge. Can you please share your screen?
Yeah.
Ayush Sharma will talk about MIS TLIF. Okay. Yes, exactly. Thank you.
And,
yeah, please.
Can you see the screen?
Yeah, we can see it.
Okay. So thank you for inviting me, and good evening from Mumbai. And I am full screen. Can you see the full screen now?
Yes. Perfect.
Yeah. Okay. Thank you. So a very good evening from Mumbai, and we will be talking, or in fact debating, two very beautiful approaches. I'm a fan of both the approaches. Before I start criticizing one over other, I should tell you I do both in my practice. I love them equally well, equally as I love both my daughters. So OLIF versus minimally invasive TLIF. So this is how I see them. My good friend from Jordan will be talking about OLIF. I have been given the responsibility to talk on TLIF. So I have divided this talk into 3 rounds, like 3 rounds of fight between OLIF and MIS TLIF. Round 1 will talk about indications. So this is a slide which I have taken from Medtronics. Now Medtronics is the first of the company in the world to introduce OLIF to the world. So if you look at the website of OLIF, all of you can go and see, you look at the indication of OLIF, it talks about very limited indication. If you read this, it says that it can be used in degenerative disc disease from level L2 to S2 up to grade 1 spondylolisthesis or rhabdolisthesis. The other indication it talks about, it can be used in degenerative scoliosis to provide anterior structural support. So if you see the limit, there is a very small indication even by the manufacturer when it comes to OLIF. And if you look at the contraindication, there is a long list of contraindication. But if you compare TLIF, we all know that TLIF remains our workhorse, or MIS TLIF remains my workhorse for lumbar interbody fusion. So what I call it, MIS TLIF is one common solution for all your indication when it comes to lumbar interbody fusion. Let's take some examples. This was a 25-year female. She had a back pain for 5 years, and she had a very high-grade spondylolisthesis. If you can see, there is a 79% slip between L5 and S1 with a slip angle of more than 50 degrees. I understand no one will dare to do a OLIF here for sure. but can you do a MIS TLIF? So we did attempt to do a MIS TLIF, and this is what we could do. Everything through tubular approach. We could reduce the slip, still doing everything MIS. We had to go up to L4 because it was a very high grade slip. And if you see, we have reduced the slip from 79 degree to 14 degree while maintaining them even with the help of minimally invasive TLIF. And this is the post-op CT scan. You can see there is a good reduction and the spine alignment looks very good. Let's take few other cases. Even for, this was one of the ischemic listhesis, but doesn't matter what type of listhesis you have. This was a traumatic, again a high grade listhesis, and MIS TLIF did the job. Or you can have a degen listhesis, like in this case, 50 female with a 73 degree slip. Again, we did a minimally invasive TLIF and we could get the job done. So continuing with the indications we have for MIS TLIF, again, look at some other cases where you can get away with MIS TLIF, but while OLIF won't be indicated. This is another interesting case which we did. This was a 30-year male presented with progressive lower limb weakness. And if you see the X-rays and the MRI picture, you can see that there at D12L1, there is a cord compression and there is a kyphosis. So patient had a cord compression and kyphosis at the same time. He was very young. Doing a OLIF here will be like committing a self-suicide because D12L1, the anatomy and the vasculature won't allow you to do a OLIF. But the question and the challenge to us was, can you do a MIS TLIF at D12L1 level? And we did attempt, and this will also show how easy it is to do a minimally invasive TLIF even at D12L1 level. So this is the video, hope it runs well. So this is the docking of the tube, you can see. And we use osteotome to do our fascectomy because I'm very comfortable with it. And it allows me to have good amount of bone graft to do interbody fusion. So I never had a problem with bone graft, which some people complain of. So this is the fascectomy, which you can see. Then we are doing the decompression here, the posterior decompression. You will see most of the cases, even for MIS TLIF, I use the regular instrument. You don't need any fancy thing. That is the advantage of doing a surgery, which is common and easily reproducible. Now we are going to the opposite side, and this is the facet of the opposite side. I'll just undercut the facets here because we wanted to have a very good decompression because we are attempting a MIS TLIF at a cord level. So we wanted the posterior part to be completely free. And now we'll start our discussion. So how much space I have? It is as easy as doing any other TLIF. The pen field is protecting my cord, and I am doing my surgery. Everything under vision. Even an open TLIF will be difficult because it won't give you the angle you want to put your cage. But MIS TLIF, even at a higher level like this D12L1, is pretty simple. You just have to understand the basics. So this is how we are preparing the disc space. Everything, the cord is under your vision, you're unlikely to damage it. And you're doing it with a very safe angle. So it becomes like any other TLIF, although we are at a higher level. And even at D12L1, we could put a pretty decent sized cage. This is a 10 mm cage which is going in. The trick here is to do it under vision, that's it, and nothing more to it. And this is how the cage goes. And look at the decompression. This is a decompression which we could do after the posterior decompression after doing this TLIF. So and then we fixed him posteriorly. And this is the post-op CT. You can see, you saw that we got a good decompression done. And this post-op CT shows a very good realignment of the kyphosis with a single level MIS TLIF. Now, again, coming to the same thought process of indication, MIS TLIF remains one common solution for various indications. What about this case? She's a female, 50-year, with back pain, neurological claudication. there is severe PI-LL mismatch. It is that lumbar lordosis, even in flexion extension, the neutral was 19 degree and the mismatch is 31.1 degree. Of course, OLIF is a good option here, but do you really need to do it? We thought, because looking at this canal stenosis here, we thought it is better to do a minimally invasive TLIF. And what we did a very generous dissection of the disc space, and we use these big cages. These are 12 mm cages. These are expandable cages, which we can expand from 12 to 14 mm to get equally good effect and lumbar lordosis, what you will get with a OLIF. And this is what we could achieve finally. The lumbar lordosis we could get from 19.9 degree to 45.9 degree, and the PI-LL mismatch, we can bring it down to 4.2 degree. So MIS TLIF remains the workhorse, and no matter what you throw it, you can do almost everything with it. The round two, let's talk about, can you always do a OLIF in all the cases, that even in indicated cases, can you always do it? I'll show you some of my examples where we could not do it for whatever reasons. So this was a degenerative scoliosis, a beautiful case to do OLIF. We planned for L2, 3, L3, 4, and L1 to OLIF. But we could manage the 2, 3, and 3, 4. L1, L2, we could not approach because it's not that easy to approach L1, L2 sometimes with OLIF. So we have to do a MIS TLIF. So even in cases where you think you can do a OLIF, it's not possible always. Finally, we could get a very good correction and a very good restoration of both the parietal and the coronal balance. And this is the final correction of the degenerative scoliosis. But again, the MIS TLIF is the one which came to our rescue, even in this case, which was planned for a OLIF. Now, again, see another case. This is if you see the spine, it is almost like a flat back. He was almost kyphotic. Again, we wanted to do a 2-level OLIF here. But look at this. The OLIF has an oblique trajectory, and it depends upon that corridor which should be there to do your OLIF. So if you see this psoas here, this is what we call a Mickey Mouse psoas. So in cases like this, OLIF becomes very difficult. Again, here you see the corridor, you have a artery sitting right in your corridor. Again, if you look at the MRI carefully, almost 25 to 30% of the cases which you will plan for OLIF, the anatomy won't allow you to do a OLIF. Well, TLIF was never a problem. So this is something called what I call as angle of attack. And this is the angle of attack should be clear for a OLIF to be done. I think my friend will talk more into it, but just to make you understand. So whenever you plan a OLIF, you make sure that you have a clear angle or trajectory of attack. So again, 25 to 30% of indicated cases, you might not have this, but MIS TLIF is never a problem, no matter what you have anterior. We did a 2-level MIS TLIF and we can get away with it. Coming to round 3, let's look at some of the challenges and complication of OLIF. While MIS TLIF is a proven technique, it's just adaptation of open TLIF to minimally invasive technique. The OLIF depends upon a corridor which goes between the psoas and the aorta. Now, psoas, if you see, is not just a muscle. It has many important structure. You have genitofemoral nerve, ilioinguinal, femoral nerve. So all this has to be taken into account when you plan to do a OLIF. You might need a neuro monitoring if you want to be very safe. Nothing like that when you are doing a MIS TLIF. It is a very, very powerful tool, OLIF. And powerful tool means it has some powerful complication. Let me show you some of our complication. This was planned for a 3-level OLIF. When we are doing the 3rd level, suddenly we have a rapid fall of BP. BP went from 120 to 60 degree, and we stopped, we revived the patient. And if you see what has happened, if you can see this, we were trying to put 2 cages and the vertebra has split in between. So powerful device means powerful complications. So you should be aware of it, all these things, before you attempt a OLIF. MIS TLIF, normally you are not likely to have so many complications. Again, OLIF depends upon indirect visualization. Means you're using a oblique corridor to put your cage, and then you do an orthogonal maneuver to get your cage straight. What if you get it wrong? Look at this. The cage has ended up almost in the canal. Fortunately, this was one of our cadaveric workshop, not a actual case, but this can happen. So you should be aware of it. So again, unlike MIS TLIF, it's an indirect visualization. It is a very, very CT guided C-arm guided surgery. One has to be very careful while doing a OLIF. Now look at some of the complications associated with OLIF. We all know the complication of TLIF. It is known, all well known to us. But look at OLIF. It can have arterial complication. It can have injury to vein, some of the notorious vein, like iliolumbar vein. You can damage a ureter. You can have a bowel injury because you are going through a retroperitoneal approach. So these are not small things. So these all has to be kept in mind before you attempt a OLIF. While MIS TLIF is like your bread and butter, you can do it anytime, just a graduation from open TLIF to a minimally invasive approach. So after these 3 rounds, I will like to summarize that minimally invasive TLIF is one common solution for all your indication when it comes to lumbar spine. OLIF, can you always do it? Even in indicated cases, almost 20 to 30% of cases, the anatomy and the structure won't support you to do OLIF. But almost in most of the cases which I showed you, you can get away with minimally invasive TLIF. Minimally invasive TLIF has far less complication, a short learning curve, and pretty safe for a regular surgeon compared to OLIF. Again, I will tell you, I love OLIF, but because I have to defend it, this is how I defended minimally invasive TLIF. Thank you so much.
Thank you so much, Sharma, for this very nice presentation. And I think you cover some of the parts of Firas' talk. Ghazwan, are you ready to present your case?
I'm stop sharing now.
Yes, please. Hi, Ghazwan.
Hi, I'm available.
Are you ready to present your case?
Yeah.
Okay. For all participants, please you can write your questions in the chat, and then we will go one by one to your questions to all faculty in the discussion part. Yes, Ghazwan, please.
Yeah, it's okay now.
Yeah, perfect.
So, returning back to my case, she's 60 years old, female, diabetes, hypertension, history of spine fixation, L3 to L5, secondary to degenerative spondylolisthesis and spinal stenosis. She did well after surgery till last 2 months when she presented with full history of falling on the ground, leads to severe back pain and both leg radiculopathy, no coda equina symptoms with failure of conservative treatment. This is her CT scan. This is at the level of the L3, which showed a fixation with mild, let's say, lucency around the screws. And this is the L4 level, and this is the L5 level. And this is her MRI, which showed that adjacent segment disease in the proximal part with the canal compression.
Ghazwan, please, we cannot see the CT or the MRI. Are you with us, Ghazwan? Ghazwan, can you hear me? Hello. Okay. Okay. Yes, yes, we can see the case presentation. Yes, Ghazwan. Yes, exactly. Now we can see the CT scan. So it's the case of yes, Ghazwan. Can you hear me?
Look, I'm sharing instead of Ghazwan now. I'm sharing the case from my device, so he can comment on the case. If he is available, I will check. Otherwise, I will. Okay.
So you can just show the case. I think he has shared the case with me. So I can tell you it was a previous surgery at I think L45, and then patient has a adjacent segment at the L34. You can go ahead with the next slides. So I think there's an adjacent segment disease, a case of adjacent segment disease basically in a previous fusion.
Yes. So next.
So L3 is an adjacent segment disease.
So next, yeah. So this the MRI, yeah.
Yeah. So this is stenosis and an adjacent segment disease following.
Is it adjacent segment disease or it's the same segment? I mean, it's
no adjacent segment. The segment above there is a problem. The above the fusion.
The fusion from L2.
L2 is the proximal. So L23 there is a problem. L34 has been fused. L34 has been fused.
So can you get back Ahmed to the X-ray?
Go back to the X-ray. Yes, 1 second. No X-ray, CT.
It's a CT.
Okay. So back to the history.
Back to the history. So she's 60.
Yeah, exactly. Yeah. So it's L345 fusion. Yeah. So it's yeah. Go ahead. Yes. So yes, Sharma, please.
Yeah. So actually, the patient is a case of adjacent segment disease, and with a previous fusion in L3, L4 and L5. So this was a question he wanted to address, the debate on OLIF versus minimally invasive TLIF. Now, let's finish the presentation and then we can discuss the case.
Yes.
So that
the investigation shows no much CRP is negative.
Almost negative. ESR is
almost
high.
negative.
And
ESR,
rest everything looks. So his question is whether will you prefer a OLIF, XLIF, MIS TLIF. So that was the question. What the patient will choose.
He gave us different options, but let us concentrate on what we are talking about, which is the MIS TLIF and OLIF, and then we can go back to his solution. Firas, how are you?
I'm fine, thank you very much.
We are glad that you are with us.
Thank you very much.
Thank you so much. So can you please share your screen? Ahmed, can you stop sharing screen?
Yes, you can do.
So Firas will talk about the OLIF, and I think he will try his best to persuade us that Sharma is not saying everything about OLIF.
Is it okay now? I'm sharing the screen.
Exactly, I can see it.
Yes, thank you very much. First of all, I would like to thank the panelists all, Dr. Muzahem, Dr. Ghazwan, and even the colleagues, Dr. Ahmed, and definitely Dr. Ayush, who did the subject difficult for me to talk about it. I'm very glad to share with you opinions, ideas about our daily practice in spine. This is my short CV. And since 1997, there is a lot of studies, evidence, the meta-analysis, review of literature about, MIS lateral lumbar fusion. And if you go through all these studies, sometimes you get confused. And that's why I believe that medicine is a science of uncertainty and art of probability. So with knowledge and skills, you can know what is the problem in your hand. And this is that I want to talk today, that there is no certain technique is excellent or good. I will defend my, the technique that I favor. But definitely both techniques, I believe the opportunity of a training and adapting technique and experience is really the favoring of this technique and other about MIS TLIF and OLIF. So what about the limitation and indication? This is that we will talk about. I would like to start with this, study. This is in 2018, and the conclusion, it's about clinical and radiological outcomes of direct versus indirect decompression. And what is the conclusion? OLIF shows less blood loss, shorter operative time, better restoration of disc height, and earlier time of fusion than MIS TLIF. And why I'm talking about this? I will explain you why. First of all, this is about, the operative time is 50% less. Estimated blood loss is 65% less. But about the hospital stay the same. But this is the important or the key of the success of a fusion surgery, which is the fusion. And if you see, there is, a meta-analysis and there's a lot of studies, but most of the studies favoring that anterior surgery, because I will show you why. The incidence of fusion is more. And if you see in 24 months, in the OLIF is 100%, 20/20 fusion, but in the MIS TLIF is about 85%. And why? Look about this, axial image of the MRI. And this is the cage of the OLIF at the A and the cage of the OLIF at the B. But if you see that 12 square sections is the intact area of the OLIF. In between the intact area of TLIF cage is about 6. So about 50% wider is the cage contact. And this favor why the wide footprint of the cage definitely more effective, provide more effective biological environment for a fusion process, first of all, and the incidence is less for subsidence. So what we need in general of fusion? Decompression, so we can, it's indirect in moderate and mild, but you can do minimal invasive decompression from posterior if it is severe, and then you go through the OLIF. Restoration of disc height, this is the most important. Realignment, which is the sagittal balance, and the rate of the fusion. So if we have these in our mind, so we have the target, and this is our target. The technique and how to adapt it is something I will show you what is the technique of the OLIF, and there is many tricks that you can do. So what do we need? We need good diffusion, we need good alignment, we need decompression. And this is that we can do with OLIF. And there is sagittal balance correction following lumbar interbody fusion. This is another, comparison of 3 approaches, which is the OLIF, MIS TLIF, and open TLIF. And they found that OLIF approach might offer a greater correction of sagittal balance. And what about, the complication? Because, I believe that in every procedure, you have a lot of around structure. If you go to the anterior cervical spine, which is, we don't have too much complication from the approach, but you have carotid, and you have also the muscles around, and you have recurrent and laryngeal nerve. So this is very important structure, but if you go the anterior, it's a very easy surgery because you are going immediately in the disc space. And this is all of the same. It's around you, major structures, but if you go immediately in a disc space and you know how to go, the complication is like exactly the minimal invasive transfemoral. The first study is meta-analysis, and meta-analysis of even meta-analysis of evidence and meta-analysis studies, and they found the complication overall rate in OLIF is 11.4. And in another systematic review of literature, they found the MIS TLIF is the complication overall 9.2. The neurological deficit is more in this is 4.2, but none of them is permanent. And the neurological deficit in the MIS TLIF is 2.2. The intraoperative complication around tissue, the intraoperative complication is 1.5 for the OLIF and 3.2 for the TLIF. And both studies are evidence because it's meta-analysis. So I would like just to show this challenging case that we can do it in both techniques, but what I did. So it's a 78 years old. She has all that you think from comorbidities. And she came with inability to walk. Dorsiflexion of both feet 3/5, and she has severe peripheral neuropathy, but she cannot walk. And she's 78 years. she has all the morbidities, and this is the MRI. And you see that in these cases, usually, especially at the level of L4, L5 even, is not enough to go indirect compression. So we have to do direct and OLIF together. And this is the MRI, and you see there is multiple. So we have 1, 2, 3, 4. And if you do 4 in this age with this quality of bone, 75, 78 years old, usually the quality of bone is osteoporotic. So can you leave this, that it's also the L5S1, which is degenerative? This is the ask. So what we have to do, we have to do 1, 2, 3, 4, in my opinion. So how you can get with the MIS TLIF if you want to open here and here and here and you resect the facets? So this is the patient. The patient is very obese. So if you go open, definitely you cannot go open, because from the end stage diabetes that she has, and she's 78 years, you know what are the complications. Nobody want to do open. So we go MIS. So what to do? MIS TLIF or OLIF? This is the dilemma. I believe in these cases, OLIF is more successful, and I will show you the case. So this is the anatomy if you go posterior. So you go through the muscles, but you have the nerves, you have the roots. You have to resect bone and facet joint, and to go in the area that you go, you cannot open all the disc space. You go from lateral, in the corner, you have the window to go inside, and you cannot see the end plates. So you go everything bluntly. In between, here is like the cervical spine. You just go through the muscles of the abdominal wall, and then you go in your finger immediately in the disc space. You can reflect the iliopsoas and not to injure it. And this is the concept. Now you have major, yes, you have. In every surgery we have. In cervical spine we have the same. So that's why the anterior. And you can see even the end blades, and you can see the upper and the lower, and you can control the injury of the end blades. Even and if you do go from a small corner and wound, you cannot control. So the damage of the end blades in all studies is more in MIS TLIF rather than the OLIF, and this is doing the subsidence of the cage is more and more. So this is the technique. I will go through the technique quickly, and we have here the vascular window, which is between the aorta and the psoas. And in my modification in these techniques, usually I don't go big. This is that I want to tell you. So I go my finger especially down to the iliopsoas, and I reflect the iliopsoas. Now, you can do this, but the preparation, the cage, and the cage insertion with the bone graft, it takes with me less than 20 minutes. So you don't have ischemia over the iliopsoas, and even you don't touch the plexus, because the lumbar plexus inside the muscle. So if you are outside of the muscles, there is no even any injury from the lumbar plexus. So about the indication, I don't too much agree with my friend, Dr. Ayush. No, we can do everything really with the OLIF. But the only thing that I want to tell you, in severe spinal kyphosis, I have to go with my tube to do decompression from unilateral approach, and then I continue all my procedure with OLIF. So what I can do, everything, even spondylolisthesis. In this lecture, we have limited time. I have even spondylolisthesis grade 2 and grade 3, and it went very well with OLIF. But in addition to this, that you can do also scoliosis. Look, this is revision case in OLIF, and I see that this is pseudoarthrosis, and I can take all the cage from the space, and you take it out because it's pseudoarthrosis. That we can do because you can open widely your cage, and this is definitely L5S1. And you take all the cage, and then you put another cage, and you prepare without going interior. And this is the cage that inside the. And the other issue about scoliosis. This is adult scoliosis, matter of 3 cats, and she has severe pain from instabilities and degenerative spine and adult scoliosis. If you see here, you see severe rotation, especially in the L2, L3. And this rotation, you know, in the lumbar spine, if you want to correct, and to correct the sagittal also, and you have to correct the rotation. If you don't do anterior release, it's very difficult. If you see that we do 1, 2, 3, and this is how much the rotation from anterior. But if you open back and put your screws, you have very good correction, coronal and sagittal. I didn't put cases revision, but I have, I do all the revision cases even with OLIF. The OLIF, definitely it needs more spinal cord monitoring, but I'm favoring spinal cord monitoring in all my cases. I have it in my theater and then do it. It needs instruments and CR machine. This is the window that we need. The position is lateral, as you see, no, all of you. This is the key of success, which is the X-ray, how to do the end plates lateral and the pedicle symmetrical. All of you know about this. And the incision you can do just from the mid of the disc space. If you landmark it in the CR machine, 5 centimeter anteriorly. And what we do, we go just bluntly with our finger through the stripping of the external oblique, internal oblique transversalis. Then with our finger, we swipe, just we touch the iliopsoas, we feel it, and we go immediately in the disc space. This is going like this, and this is our target. Then I go down to the iliopsoas, I put my target. I don't want to be oblique. I want to be it more center, more lateral. So then I do my opening, and this is the incision. The incision is very easy. You know, this is, sorry, yes. So you see the muscles that you strip the muscles, muscle by muscle, and without, you know, seeing any blood. I don't have usually blood loss in these cases. If it is a single level, nowadays we don't have more pain. We don't have at less than 100 cc of even with posterior fixation of the screws. Here we don't have usually any blood loss. And then you see the 3 muscles that we stripping without any blood loss because we don't injure it. Then this is the third muscle, we open it, and after that we reach the transversalis, and this is the fat. This is the yellow down the fat, and then we go with our fingers. And after our fingers, we put our retractor inside after the dilators. The first dilator, we just push it inside the disc, and this is the other dilators. We open the retractor, as you see, and then you see that there is usually no blood. Even in your finger, you don't see blood. And this is the technique. The opening is very easy. It takes with you very few minutes. It doesn't take too much time. And as the anterior surgery, you go immediately in the disc. As the cervical spine, you see the iliopsoas. In this case, I have this video is not the proper to see the annulus fibrosis, but you can prepare it very well. You can see the edge place very well, and then you insert your cage after insertion, the sagers with bone graft. This is the L from L2 to L5. I agree with Dr. Ayush that L1, L2 is not the area for OLIF at all. And I believe, in my belief, you know, L1, L2, if you have severe, you know, stenosis there, usually there is no shearing force. And usually the disc is collapsed. And you don't need to do too much, you know, anterior body fusion. This is my opinion. This is not, you know, the standards, but minimal invasive decompression by tube. And if it is degenerative, you know, facet joints, and you need to fixation, just to fixation by minimal invasive technique. Even in my everyday daily practice, I don't do too much, you know, interbody fusion. If the problem is just anteriorly in the disc and the facet joints is good, so we do just minimal invasive decompression. I favor, you know, the fusion if we have instability or we have severe degeneration. The L5S1, we're going just between the vessels. Yes, we protect the major vessels. And this is how to design the incision. And after that, this is 2 fingers from only the anterior iliac crest. We open we open the wound as you see, and even in L5S1, I believe is more reproducible technique than up. So because you open here just the aponeurosis, external oblique aponeurosis, this is the only thing that you open, and then immediately if you just do stripping, you see that this is the fat, the retroperitoneal fat. So with your finger, we swipe to see just, you know, over the iliopsoas muscle, and you feel definitely the major vessels, and then you put your retractor and you can see inside all the structure you need. Definitely in our retroperitoneal, there is a lot of structure, as Dr. Ayush said, but if you do it proper, the incidence of injury of around tissue is very, very, very minimal. After we open, this is the mid-sacral artery, mid-sacral vein. You can cauterize it, and then you go immediately, you cut the capsule. You cut the capsule as exactly in the cervical spine, and then you see the end plates. You prepare your end plates to see it up and down. The damage of the end plates is very rare in these cases. Then you put your sizer, then you put your cage as you see. And after that, this is the end result. So, and this is the cage that we put from anterior, and this is the incision is about 2.5 centimeter, 3 centimeter. We go back to our case that we said, and what I did in this case, we first of all, we did the L5S1, we put the cage, and then through single incision, I did the above 3 levels of cages from the same, it's with the OLIF, without real, it's small ones. She's in the stage diabetes, can be closed, and this is the incision. 2 incisions, I did all the fusion. And in the mid here, if you see, I decompress by my tube the severe stenosis that she has. And this is, as you see, the lateral recess compressing the nerve root here. And after that, this is the this is the end of the surgery. So I introduced the 3 levels. I did the fixation. I did the compression from the same patient, for the patient with real no serious complication. So in my opinion, easy reproducible technique, many applications and indication. You can control from L2 to S1, low complication rate or comparison even in other techniques. So it's a new option for new patients. Thank you very much.
Thank you so much, Firas. Very, very, very nice cases and very excellent technique. Thank you so much for this presentation. Ghazwan, can you share your screen? Can you show us the solution of your case before we will go to the discussion?
Okay, keep talking, Dr. Ghazwan, please.
Yes, Ghazwan?
This is your last slide.
Ghazwan, can you hear me? So if Ghazwan cannot hear me, please, Ahmed, can you show us what's the solution? So what's the plan? Yeah. He's in love with cars. He's in love with cars.
So he removed, I think, all the screws from L2 to L5 pedicle screw fixation he did. Then he did L2, 3, L3, 4, L5, L4, L5, TLIF.
So it's an open technique or MIS technique? Ghazwan, we cannot hear you.
Please defend.
Can you just write in the chat whether it's an open technique or you do it by open technique or MIS?
Maybe Ayush can tell because he knows everything about it.
I think he has done a open in this case. That's what I feel. So I think these are challenging cases. But with the permission, before I conclude, I want to show 2 more slides, because what I have told is one view of MIS TLIF. If you allow me, I'll show you 2-3 slides, what I think is the balance between doing a MIS TLIF and OLIF. If you can allow me Yeah.
Okay, okay. Go ahead, please, Ayush, because we have short time and we have a lot of questions. Yeah.
Just 2 to 3 slides because
yes, please.
Yeah.
Go ahead, please. Yeah.
So this is what I told you, but see, I myself is a big lover for OLIF, so it won't be biased to just talk about one thing. So I prepared 2 slides to have a general viewpoint as a person who does both the techniques. How do I believe into it? So this was the challenge. So what I feel is OLIF is one more way to do interbody fusion. So it gives you one more way to do your case, and in selected case, it could be the best way to do it. That is how I take it. Take cases like this. This was a bad case with a kyphosis, with a scoliosis, previous surgery. Now you can do it MIS TLIF, but then you have to go through scar, you have to do multiple level surgery and all that. So this is where my OLIF comes. I believe the sledgehammer. That's why I gave the Thor to the OLIF. And single level OLIF, you have achieved everything: the kyphosis, the scoliosis, and the indirect decompression. So, and this is with a 2 centimeter scar. That's it. Now, the case which Rajwan showed is exactly the similar case, a ASD with previous instrumentation. What Rajwan did, you can do that, but you can do this, which is far better. A single level OLIF. You do it within 1.5 hours, 20 ml blood loss. You fuse the surface, you get the reduction, and look at the scar. The previous surgery was a 4 to 5 centimeter scar, and we have done everything with a 2 centimeter scar. But remember this, the Spider-Man, it tells you that with great power comes great responsibility. That is what is very important. So
thank you, Ayush.
Yeah. One last slide. So OLIF is like doing a ACDF in lumbar spine. So while TLIF remains my workhorse, I use OLIF in selected cases with remembering this message from the Spider-Man that with great power comes great responsibility. So I really wanted to share it before going in. Thank you so much for giving.
Thank you so much, Ayush. So what I understand from you that if the Ghazwan's case is yours, you will go for only OLIF.
Exactly, definitely.
Single level OLIF. What about fixation? What kind of fixation you will do? How can you manage to fixate L2, L3?
Ayush, can I ask you, please?
Yeah, please, go ahead.
Yeah, the idea that the case has a pseudoarthrosis for all levels. So if you are planning to do OLIF, you will remove the screws, or you will put it and do all levels.
So what we have done is, in this case, as you can see, we did the OLIF and put a plate from the side. So that is what you can do. So this is how it is. You can see this. There's a plate from the side. So everything you can do through the OLIF. So this is a plate. Can you see this? With this going? Yeah. So you don't have to go posterior at all. This in selected cases like this, it makes a lot of difference between doing a surgery, which Rajwan did, beautiful surgery did. How much time did you took, Rajwan? Now, what is the blood loss? How long did you took to do that case?
Yeah. It's a massive. It's about 3 hours, and might be 1 liter of blood loss.
Exactly.
I know. Agree. But the idea that you will revise it only 1 level. What about the pseudoarthrosis of the other levels? You will tackle it or not?
So it depends. This specific case, maybe if you feel there's too much of pseudoarthrosis, maybe you have to do something. But at least for the adjacent segment, it works beautifully. I'm not saying.
Yeah, sure. It's ideal.
So the message, Ayush, that you will tackle only the maximum pathology and the maximum complaint with a minimal invasive way.
Yeah, so it is like a Thor sledgehammer. You don't use it always. You keep it, and you use it when it suits you the best. That is how I see it. My good friend from Jordan can put his viewpoint. That is how I see it in my practice.
What about Firas?
Yes. Many thanks. Yes, Firas.
Thank you. About adjacent recurrent level, I agree with Dr. Ayush. OLIF is really the solution. I have until now about 14 cases of recurrent adjacent level, and I did standalone without plate, just standalone cage, and that fusion rate is very high. And I did it because I see even in the literature very supported and evidence study about this. They did multi-center study about this. But in your case, it depends. I didn't see the MRI very well. But look, you have first of all the adjacent recurrent. You have very good in the plates. It's sclerotic. So if you put the cage, the cage will be very powerful inside, not to be osteoporotic. This is the first. The second one is the symptoms and the signs. If there is no signs of neurological deficit, is excellent. The symptoms should be mechanical. If it's constant pain, you have to do direct decompression. If it is mechanical pain, it's indirect is more than enough. So if it is mechanical pain, even it's very worse. Just if she stay in the bed and there's no pain, indirect is enough. But it is even in the bed is pain, you have to do direct decompression. So I believe indirect for recurrent adjacent level, the treatment of choice in my humble opinion is OLIF standalone. And I agree with Dr. Ayush with this.
So let us start with the discussion, and the fun is here. Many questions from the participant and from us. Let us start with Sharma. Sharma, please, we have these questions, and please, if you can answer this question from the participant. Yeah, your friend Anthony asking about, do you use a cord monitoring for MIS TLIF or OLIF you used in your...
No. So cord monitoring for the case which I showed you,
yes,
that was D12, D11 level. So
yeah,
we have done MIS TLIF even up to D11, D12. For all those cord levels, it is better to have neuromonitoring, but we don't do neuromonitoring for the rest of the MIS TLIF. For OLIF, although I have a neuromonitoring in hospital, but for OLIF, I don't do it neuromonitoring for only reason, except for very few selected cases. Only reason, if you're doing a neuromonitoring, you cannot use your the muscle relaxant. And I find it much easy to do the OLIF surgery so that I can retract the psoas nicely and do my OLIF. I do my OLIF under direct visualization. I see everything. We keep a neuromonitoring standby if in case I need it. But in 90% of the cases for both MIS TLIF and OLIF, I won't use neuromonitoring unless I am at a cord.
Good. Question from Janelle. Do you use a banana cage or bullet cage too? Sometimes in some cases you just only use a bullet cage.
I prefer the the bullet cage because it is easy to put, but it is I don't think there's a problem. It's up to you how you have been trained. In case of MIS TLIF, it is a bit easy to put those bullet cages, but I know people who use those banana cages. So it is up to you what you're comfortable with, what is your teaching, what is your background. I don't think the design of the cage makes much difference.
Okay. Another question from Hamid. What about the biology of fusion in MIS? How to achieve this fusion? What's your fusion rate in both techniques?
So when it comes to MIS TLIF, as I showed you, I use osteotomes to get out my facets. So that is how comfortable I am. So I have enough bone graft, as much bone graft as you get for your open TLIF. I can get that much amount of bone graft for MIS TLIF. So fusion is never a problem with me when it comes to MIS TLIF. OLIF, I think you need to have the synthetic material. Let my friend come in. I think let him give the OLIF talk. I should not talk on OLIF today.
Okay.
Okay.
Our friend
your material for OLIF, you can please.
Yes. Okay. So our friend Reber also asked about the same question about did you use a bone chips or you use your autologous bone graft, or what kind of bone graft you use for MIS?
So what I don't use normally. I'll use for at least for the facet part, as I showed you, even for a level which I thought I'm very comfortable with using the osteotome because that's how I have been traditionally trained. So I know, so it gives me a lot of bone graft. So never I had a problem with the bone graft for MIS TLIF. OLIF, again, you need synthetic bone graft because there you don't have any bone for sure.
I have a question in cases where you use an MIS TLIF. You showed us a case of high-grade spondy. So what about the cases with bilateral symptoms and bilateral radiculopathy, and you are using only single one side MIS TLIF? How can you decompress the contralateral exiting nerve root?
So you can do it very easily. What I showed you, you can go to the tubes allow you great amount of freedom. So what you do is you tilt your tube and you tilt your table. So this is how this is how the spine is. So this is how you look at it. So once you're on this side and you want to do the contralateral side, you tilt your tubes, and as you tilt your table, you will be able to do it. So the beauty
we call it wanding. We call it wanding technique. But again, you can reach the traversing route with this technique. But how can you reach the exiting route?
So even exiting route, you can do it, but not in a high-grade spondy for sure.
Yeah.
So high-grade spondy, I have a different technique altogether. So what I do, I don't reduce it, because if you try to reduce it, the roots are likely to crust, and that is the biggest problem with the high-grade. So what I do, I first increase my disc height. So I'll put my shavers. Sometimes I use 2 tubes from both the sides, and like a paddle shift, I keep increasing the disc height. Only when I have gone to a certain disc height, and already by this time your nerve roots are decompressed, then I try to reduce it. So if you see the slides, which I showed you, I have not put my screws till the cages are in. So I get my disc height first, and then by that time already you are reduced, your foramen decompressed. Recently I reviewed our cases. We have 40 cases of high-grade listhesis. 20 of them have been MIS TLIF without much complication. Although we do use neuromonitoring for the sake of it, because we have it. But we never had a problem, because we are following this technique where we get the height of the disc first and then we reduce it. By that time, your foramen already decompressed. I think that is the trick.
Yeah, you know, Ayush, I'm totally agree with you. As most of the paper recommend the bilateral tube and fascectomy in high-grade spondy, because even with the technique that you mentioned, might be a problem, especially in your reduction technique.
Yeah. So it is totally depends. We keep both the tubes ready, but I'll tell you, 80% of the time we have been able to do it.
Insufficient indirect decompression in your cases. Now the patient is still complaining from radiculopathy or failure of indirect decompression that required revision surgery from posterior, in your experience.
I'm talking?
Yeah.
Yes.
You know, about me, you know, in the beginning, really, I started the OLIF in 2008. So I have, you know, hundreds of cases, more than this. So in the beginning, I have, you know, really high incidence to do the compression from the back. Habit is less than 1%. And the key is the surgeon and how to select his case around, you know, the complaint. So you see your complaint. If you have, as example, severe intermittent claudication, remember that severe, that less than 20 and 30 meters, less than 30 meters, 20. So remember that you have to do the compression. And the other issue, you see the MRI and you compare the clinical between. But if you have, you know, even intermittent claudication, more than, as example, less than 100, more than 50, and the patient pain is mechanical, even inflammatory, but he tell you that example, when I just, you know, do a little bit, you know, or when I do lumbar flexion, I relieve. So the foramina, you can, if you open that foramina, everything is well. Now about lateral, which is foraminal stenosis, the success rate is very, very high. The problem is the central. This is the main issue. So you see the central in the MRI and you see the clinical, the complaint of the patient. And if you do it in the right way, the incidence is very, very, very low. But in the beginning, if I see that, you know, there is central really and severe stenosis, I do with a tube direct decompression and I do OLIF. In this case, never I had any case of prominent, you know, stenosis. And I do the technique that Dr. Ayush said, that unilateral approach and bilateral decompression, which is well known for every surgeon nowadays.
So I completely agree with my friend that the most important thing to get a good result in OLIF is the case selection, and case selection. If you select the right cases, you won't fail with it, like any other surgery. Now, you have to select the cases right. The cases, and it will come with some experience. But still, if I have a doubt in my mind whether to go with indirect decompression or requires a direct decompression for a single level, or maybe even up to a 2 level, what I will do, I will add a direct decompression as well. But if I'm doing a multi-level surgery, what I do is I stage them. I do OLIF on day 1. I make the patient walk on the same night, and they will walk without pain. They are the most painless people you will get anywhere with any surgery. Let them walk. Let's see how they respond. If they have anything, like they're saying there is still some pain, some radiculopathy, you get a MRI done. See if you can locate that area from where the pain is coming, and you do a limited decompression, tubular, when you do the second stage posterior fixation. Now, in a big case, I think it saves you time, energy, it saves you complication, and that is how I do it when it comes to OLIF. But case selection, I think, is the most important thing when you select a case.
Thank you.
Thank you so much. Firas, we have a question from Anthony. Do you counsel your patient about possibility of second surgery after OLIF?
What, please? If I?
To counsel and get agreement with your patient about the possibility of second surgery when you do only OLIF.
Yes, if I had, some, if it is really severe stenosis and I have to do it from the beginning, I ask the patient. I tell him that, we have success rate about 80% if we don't do decompression. But if there is 20%, I do decompression later. And sometimes I don't ask them. I told them that I will start with decompression first and I will go for OLIF immediately. And usually I do lateral OLIF and then I do decompression, from the back with the fixation. Sometimes if I'm worried about, to have remnant, and I need direct decompression, yes, definitely. I agree with the patient from the beginning. Otherwise, it will be terrible for him after the surgery that he needs another surgery. I agree. This is the best I do. And just, I want to tell you about OLIF and what I do. I have, series of revision surgery. And if you want, I can share you some cases now, but, I don't have the time, but I have one, about to know what about the revision. From simple revision, like, double discectomy or a triple discectomy, if you go back, you see a lot of adhesions and maybe there is even injury of the dura or something like this. So go to back is difficult. And you see the disc collapse. In this case, direct is more than enough. And it's a very easy procedure. And even in major, multiple laminectomies with adhesions, with these problems, definitely you can select where you want to decompress by tube, and you can do all that procedure with OLIF without blood loss, adhesions, risk of injury of the nerves, and I have series of revisions in all types of diseases with OLIF, even infection, the same.
Thank you, Firas. Firas, we have seen you doing the nice case in L5S1, but I have this question, and it's again also a question from one of our friends, Thaqaf Fadl. If you face like a large aberrant iliofemoral vein branch, or in cases where you need to do difficult to retract the iliac veins and iliolumbar veins, and you will carry more risk in doing OLIF in L5S1. What's your tricks how to do that?
Yes. Now the problem is not these delirium, but sometimes we have the bifurcation at the level of L5S1.
Yeah, this is one of them. Yeah.
In these cases, in the beginning, of L5S1, I started it in 2014. At the end of the 2014, I started L5S1. So I have till now more than 300 cases in my private clinic. So I had complications about vascular. I have just very low in the beginning, and we have low bifurcation. And my vascular surgeon at that time, I don't have vascular surgeon more, but in the beginning it was vascular surgeon. He believes that he wants to do it even it's a low bifurcation, and we have injury of the vena cava. And that's why I believe if it's low bifurcation, don't go in between, never ever. And in some cases, one of the cases that we have a problem that we have to go. And I asked the vascular surgeon what to do. He did, by the vascular surgeon from this incision. We did the incision more big. My incision is about 215 centimeter. We did the incision is about 8 centimeter. And he did lateral dissection of the veins from lateral to from left to right. And then we have like the OLIF exactly. We go from the corner, and I did my I didn't from the anterior. I went from the lateral anterolateral of the disc, and we did. So in these cases, which is minimal to have low bifurcation, whatever the vein and the aorta big, if the bifurcation is above, you can control. The problem is the bifurcation is low. So you go from lateral to mid by the vascular surgeon, and you can do your surgery.
Yeah, this is a very nice.
I believe the L5S1, the problem of the L5S1, you can find it even in the MIS TLIF if you have, as example, collapsed disc with severe lordosis. So it's very difficult to go from the back. So because of the severe lordosis, I believe from anterior is more easy, in my opinion. I do both, but I do more and more OLIF. I selected to MIS TLIF if I have, sometimes we have contraindication in the OLIF. I want to tell every one of you, if you have in the end plate, as example, istified, and this istified, hooking the nerve root in the foramina. So if you do direct, if you do expansion in the disc space, the nerve root will be hooked with the foramina, and you have a radicular pain. So in these cases, there is relative contraindication. You have to go from the back and to take this istified. So in this case, I go usually on my TLIF because I take the istified and then go from the same way. And this is the only that sometimes I see, and I don't do OLIF and then do my TLIF.
Can I add something? So
yes,
so
very fast, please.
Yeah. So if you're as experienced as my friend Firas, you can attempt a OLIF in those difficult scenarios. If you are me, then I will do a traditional MIS TLIF. You read your anatomy well, you read your section MRI. If you see something, there's always an option. So yes. It is better to not have those complications and then to have it. So as I showed you the last slide, the OLIF, I'll keep it in reserve, and cases where I see the anatomy unfavorable, I will use my workhorse, which is a MIS TLIF.
I do all my cases for favor of rate of fusion. This is my important. Fusion and the sagittal axis. If you don't have fusion, patient will come to you after 1 to 5 years, he will come to you. And if you don't have sagittal axis, he will have axial pain, and this reflects in you as a surgeon. So my target is to have a good diffusion, good decompression, and good sagittal axis, which is the most important.
Because we run out of time, I have one last question from Saad to you, Firas. What about standalone OLIF? What's your experience about OLIF without screws?
Yes, thank you, Saad, for this question. This is a very important question. I did, I do it. Why I did the standalone in the recurrent adjacent level? Because in all recurrent adjacent level, if you see the index plate of the vertebra is very sclerosed. So there is no, there is very, very, very low incidence of cage subsidence. But in standalone, what the studies showed till now, that the incidence of subsidence is higher a little bit. And, even either you do plate fixation from anterior with the cage alone, because first of all, if you have multiple cages, the incidence of union definitely is more high than one level. And the second issue, the important, that if you don't stabilize also from the motion from the facet joints, there is subsidence of the cage. That's why till now, I do only if it is one level and recurrent adjacent level. I'm waiting more studies because I'm working in private section. I don't do studies in academic or governmental. So I'm waiting studies to support, the anterior standalone in multi-level to do it and to be more brave with it. Nowadays, I do just posterior fixation because I don't see any evidence study that it's a very safe and effective like posterior and anterior. The problem is the subsidence of the cage.
Thank you so much, Firas. Thank you so much, Ayush. I can just, it is a big subject. I know that's a big subject, a big debate, actually, but the time is too short. So I can just summarize my take-home message that to our participant that study your case properly according to your available resources, and do what's best in your hand according to the evidence-based medicine. At the end of this webinar, I would like to express our deep thanks and appreciation to our guests, Dr. Firas, Dr. Ayush, and Ghazwan, and Ahmed, and to all our participants for being with us, and hope to meet you again in other webinars and activities. Thank you so much.
Thank you very much.
Thank you. Thank you, Muzahem.
Thank you so much.
Bye.
Thank you, everyone. Bye-bye.
Thank you, attendee. You can see the recorded webinar on YouTube. I will send the link for you in 2 hours. Thank you very much.
Thank you, Ahmed, for your effort.
Thank you.
Bye-bye.